Welcome back to Stop Feeling Like Shit. And I'm your host, Danielle LaCourth. There's no Dr. Buzz today. Sad. Instead, we have Joseph Matovich from Buckeye PMR and Anti-Aging. And we have Dr. Mack in the house. Welcome them back. Hi, guys.
Thanks for having us back.
All right. So in today's episode, we take a deep, honest look at male hormone replacement therapy and why it has become such an important conversation in modern men's health. Low testosterone is no longer just an aging issue. It's a quality of life issue that affects energy, mood, body composition, motivation, and long-term health. Would you agree?
Yeah, I would agree.
Yeah. So, I'm just going to start asking a few questions if you don't mind.
Okay.
All right. So why are we seeing so many men today with low testosterone compared to 10 to 20 years ago?
There's a big argument for multiple things. Most of what we see with men is secondary dysfunction. The problem, generally speaking, not being at the testicular level. I would say it's a combination of lifestyle. People are less active jobs. And then what we're seeing environmentally between microplastic exposure, glyphosate, environmental toxins that are generally disruptive to hypothalamus and pituitary, the regulatory center of the endocrine system. So we're seeing a lot more secondary dysfunction in men where essentially environmental toxin exposure and lifestyle has just wrecked our endocrine systems.
Yeah, and I see that right with women too.
Yep.
What symptoms usually bring men in asking about hormone replacement for the first time?
So most people, generally speaking, when they think of testosterone, they think of like muscle building and sexual function, but that's atypically what I see most of the time. The vast majority of male patients that come in have primary complaints. They don't have the vigor for life anymore. So they're no longer motivated. They don't enjoy anything anymore, which is generally depressive symptoms.
Yep.
And a lot of them have been diagnosed with clinical depression or things like that. So that's the first one is, maybe their libido's bad, but sexual function's fine. But they're like, I'm not motivated at work. I don't want to get off the couch. I can't talk myself into going to the gym. I don't like doing stuff with the kids. My wife and I feel distance. I just feel generally checked out of life, right? That's the first one.
Yep.
And I went to my doctor. They put me on Lexapro or something. And it made my symptoms worse. And, they checked my levels and said it was fine. The other one we're seeing more prevalently now is advancement of comorbid disease, right?
Yep.
People that are, in our age range, in their 30s and 40s, that are pre-diabetic, high cholesterol, hypertension, they're obese. And now they're on a myriad of drugs to combat those symptoms. And they're finally looking for a way to improve overall clinical outcomes from a total health perspective, right? And
Yeah.
they're like just looking for any answers that will help.
Yeah. And at what point is low T? Like, what is low T? Let's talk about that. Like, what's the average? What are, I guess, your traditional modern medicine providers, family practitioners looking at compared to what we look at? Because, sometimes when you talk to people and they say, oh, my test is fine.
So, what most doctors treat off is what's called a total testosterone. The normal range for the CDC right now is 264 to 916. It used to be 348 to 1197. It dropped a little less than a decade ago. I can't remember the exact date that it dropped, but I was already in the space when they dropped it. So it has dropped about 30%, which is kind of crazy because you would say, okay, that indicates a decline in the health status of men. But nobody really asked questions like, why did it abruptly drop 30% when we started incorporating the youngest generation of men, 19 to 39, into normative data studies? Like, that's a concerning trend. So, that's total values. There's normal and then there's ideal, right? So if you're below the normal range, just know that from a diagnosis standpoint, that means you're functioning at 25% of normal function or less. So a lot of primary cares operate solely off that normal range, where it's like if you're not less than 264, some people even go less than 200, it's not considered low. We look at it from a more functional perspective. We don't just look at total. We also look at free testosterone. So when you look at total, I always say that's kind of like looking at your paycheck before taxes. Like, it looks nice on paper, but it doesn't mean a whole lot. Because when you look at your total testosterone, it's going to go several avenues. Some of it aromatizes, which means it converts to estrogen. The vast majority, about 98%, can get bound in the blood by different proteins like sex hormone binding globulin or albumin, which largely render it unavailable to the cell, although theoretically you can get to the albumin-bound testosterone. What's left over is your free, and that's what we'll get like 5-alpha DHT and 5-beta metabolites out of. That's your usable testosterone. That's a significantly more meaningful value for us because that equates to what you get to use. That's your post-tax money, right?
Yeah.
So we're evaluating two things. We're evaluating total and free. We're also evaluating subjective symptoms. So where we may look at, okay, your total testosterone is 400, right?
hmm
And your free is maybe it's 9 on a possible scale of like 7.2 to 24. Is that clinically normal? Yes. Is it within the bottom quartile? And does that correlate to the potential for advancing metabolic disease? Yes, it does as well. So where we look from a treatment perspective is a combination of subjectively, how does the patient feel? And
hmm
also, is this, although it may not be clinically low, is it at a threshold where we know if we don't treat it, there may be long-term deleterious health outcomes by not correcting it. So we don't operate solely off of the normal or not normal, right? We operate off of, is there room to safely move this value and elicit meaningful metabolic and subjective benefit for how this patient feels?
I think what I like the most too is that you said, how does the patient feel? Because it's not always, I hate when you go to the doctor and they're like, but your blood work is normal.
Right.
And it's like they totally disregard how you feel. Okay, well, I'm still telling you that I feel like shit. So what are we going to do about it?
Right.
Right. And so I think that's a very good point. It's like, how do you feel? And like, even though the blood work says X.
Well, and it's one of those things where like people just accept that their hormones decline as they get older. But it's, let's say you take a 45-year-old man who gets his testosterone checked for the first time at 45, okay, and maybe his free is 7, maybe it is low. Well, we don't know where it was when it was 25, but maybe it was 20 or 21. Um, you know, if it's still reduced by 70% in that time frame, right? Like they're still going to feel bad. They're going to subjectively notice that change, and they're going to have the metabolic consequences of that change. So it's hormones are always 50% labs, but they're also 50% subjectively how a patient feels.
Yeah.
And that's how treatment adjustment goes. You may have a guy, you get his free to 20, he feels perfect, right?
Mhm.
But if the upper end goes to 25 and we've got 5 more points to move safely, then patient B comes in and their level's there and they don't feel better. Well, you still got room to titrate and adjust. So it all has to be individualized based on patient response.
Yeah. And another thing is you were talking about age ranges. And I just want to say, especially in today's world, we see a lot of younger age men with very low testosterone.
Yes.
Very, very low. And so tell me what it looks like if you see a 20-year-old versus a 30-year-old, like a 56-year-old. Like, what are the goals with them? And tell us a little bit about each. Because, I think Brock or Blake had
Yep.
their levels tested. And we were completely in shock because we're like, dude, you got levels like a 80-year-old man,
Yep.
And I'm not saying that because 80's not even in today's world, to me, 80's not old anymore, right?
No, you see 80-year-old dudes walking around looking great. So
Yeah,
Yes.
like looking like studs, right? So, I mean, I can't even say, I hated saying that to him, but it's like, what are we doing?
yeah.
Like, why?
So in what I would say is in younger men, we generally tend to see secondary dysfunction, right? And what that means is the problem really is not testicular. The problem is secondary in nature. The problem lies somewhere at the hypothalamus and the pituitary level, where there is a break in the communication loop of their endocrine system, where the testicles may be functionally or structurally intact. Basically the ruling glands that dictate the function of the testes, the hypothalamus, the brain, and the pituitary, they're not responding appropriately to their testosterone level. Okay.
Mm-hmm.
And in that response, it's kind of, I would say the problem isn't the engine, the problem is the gas pedal, right?
Yep.
As men get older, we maybe in their 30s and 40s, we start to see multi-level dysfunction where maybe the pituitary is not working as hard as it should, but we're starting to see some Leydig cell dysfunction where there's evidence that maybe both of those systems may be contributing to dysfunction, where maybe the testicles have declined and the pituitary is not doing the right things, not overtly, but could be doing harder. As we get into the older age patients, then we start to see that primary hypogonadism tends to be more prevalent, which means the problem is actually at the testicle level, where those cells do not function as well and they're just not producing testosterone adequately anymore. So, lab values, low lab values or low lab values, regardless of causality. But the change, the difference we typically see is what is the causality? Is it communication loop issues, brain pituitary level, or is it primary is the problem, the testicles? And older guys, it's generally more testicular. Younger men, it's usually up here.
Okay.
Yep.
And what do you think like for the audience listening, and maybe you have younger kids, right? Because I think Brock ended up getting his levels checked when he was 15 or 16.
Yep.
And it's like, oh my God, I can't believe you're checking. He's so young. And so in today, with the way everyone's operating, right? Everyone's super high stressed. They're eating like shit. You have all these chemicals and toxins and all this stuff.
Right.
And so I think years ago, maybe people would hit a certain age and they would say, let me go get my hormones checked now. And so now I feel like what age, should we be saying like, let's check your hormones as a male?
Yeah. Well, I mean, there's value in checking it at any time, I think, once a young man starts to hit puberty. Now, there is relative age scales and developmental scales where testosterone values will change year to year as far as what's considered normative up until the age of 19.
Mm-hmm.
So even for a kid that is not 19, that's not an adult yet, you still have normative data to compare that against. And there are things that influence that. Like kids go through puberty at different times, right? I always said, like, I've looked about the same since I was about 13 and then I just never grew again, right?
Right.
Whereas we've had some friends that like came out of high school at 5'10 and left college at 6'5,
Yeah.
right? So individual interpretation relative to the developmental stages of that patient still matters. But it's always good to have baseline metrics of data, right? So I'd say when it's valuable to check, especially in younger kids, we see it a lot in young athletes.
Mm-hmm.
And I think why that matters then is, obviously you're not going to put a high school kid on testosterone, but if it's egregiously low and he's otherwise, men or women, but they're otherwise normally developed, right? You look at Brock. Brock's what, 6'2", 6'3"?
Yep.
And he's been a tall, muscular kid since he was in high school.
Right.
So you could look at Brock and think that as far as maturation goes, he's probably ahead of the curve. Same thing with Blake, is most kids their age would have been, but egregiously low testosterone. So the big concern there is, okay, what else does this point to, right? Does this point to abnormal stress response where the kid's having a problem? Does this point to dietary, inflammatory issues? Does it point to environmental toxin exposure? So even if you're not going to do anything directly about it, which you wouldn't at that age, there's other things that you can functionally correct that help bolster the endocrine system to function optimally even at their age.
Yeah, I was going to say, because, you don't have to put them on hormone replacement therapy.
Right.
You can do other avenues like functional medicine or certain things that you can do, right?
Yeah.
Which we just
Are
talked
there
about.
natural ways to boost up testosterone?
Yeah, when you look at that, and the reason it's so prevalent in kids now, I believe, is there's such an overprevalence of HPA axis dysfunction where these kids are just tuned up all the time, right?
Yeah.
You see it in sports with overtraining all the time, but I don't want to just only attribute it to sports because being a kid kind of sucks now.
Right.
So
Crazy.
It's not like we were growing up. Like when I was, 10 and 11 and 12, I was still playing with my Barbies.
Thank you.
Yeah.
Yes.
And now I see these little girls that are, 10, 11, 12, 13. And I'm over here like, you're 12?
Yeah.
It's the
You
same thing with
look
the
like
boys.
you're 19.
Yeah, it's the same thing with the boys. You see, like you said, I was still playing with toys at 12.
Yeah.
And now you see 12, 13-year-olds, that's not the case.
No.
You're seeing 12-year-olds with, like you say, with beard
Facial
like Joe.
hair. I know,
You
look like men.
Yeah, so, and you seeing also, I was a byproduct of it, but the hair loss.
Yeah, the hair
Right? We
loss.
starting to see that at 13, 14, 15
Yeah.
years old with these kids.
I think the activities and the stress that kids are forced to participate in at their age now is a lot different too, as far as social pressures. Social media is, I think, a big part of it. Kids operate differently too. They don't go outside. They don't spend time with their friends.
No bike riding.
No bike riding. They're less
No
physically
nothing.
active.
Exactly.
But because of the lens of kids, because of social media, because of social pressures, I feel like they're constantly under scrutiny. So we see a ton of kids with their adrenals that are their HPA axis, I should say, are trash. And we know with chronically high levels of CRH from the hypothalamus, it suppresses GnRH and TRH, which shuts off the pituitary. So we see chronic disruption to not just the HPA axis, but those other endocrine systems when stress response is always.
Right. Yeah.
So that's what we see a lot. And then you couple that with inactivity and trash diets. I think one of the things that Joe Gambardella mentioned on one of the previous podcasts is there's all types of stress that we don't think of as stress,
Right.
inflammatory stress, dietary stress, things like that. And they all elicit that negative adaptation to the endocrine system.
Yep. So let's talk about what are some different ways that testosterone can be delivered and why they're not all equal.
Yep. So as far as testosterone therapy itself, we generally defer to two modes for men, and that's either injections or subcutaneous pellet implants. There's a few different ones out. There's a new mode called nasotest. I can't think that's the drug names, where it's actually a nasal swab that
Wow.
absorbs through the mucosal barriers of the nose, but you have to use it 2 or 3 times a day because it's really fast acting.
Okay.
Which the more often a patient has to take medication, the less likely they are to be compliant with it.
Right.
There's transdermal delivery or topicals. We don't really like those for 2 reasons. Well, 3 reasons. Efficacy tends to be poor. We just don't see them move the dial enough for men. The second one is transfer risk. Obviously, like the relative amount of testosterone you need is way different from a male patient.
Right.
So, let's say Buzz was on topical testosterone and slops a bunch of androgel on his arm, and then you run into it and it transfers to your risk. Like, that's going to be a different consequence for you, right?
Yeah.
Same thing with kids. Really, we worry about with kids. So injections or pellets are what we tend to defer to the most. Injection approach, I would say, has changed a lot over the last few years. We've definitely moved more aggressively into like a microdosing type of schedule where we're having patients take their weekly dose and break it up into small, more frequent doses because it more closely replicates physiology and it minimizes peaks and troughs. That's what we defer to the most.
I personally know that I like it that way
Yes.
myself,
Yep.
especially with my lifestyle. I
Yeah.
think it goes very well with what I do.
Mhm.
So I like that.
Yep. And then pellets, they're little pellets stuck in the subcutaneous fat and the glute that metabolize over 3 to 4 months. We have some male patients that do it just because they won't be compliant with injections and they miss their doses. And if you don't take it, shit doesn't work.
Right.
But pellets, they work well. The only struggle I see with those with male patients is if you're a really rapid metabolizer, you're still going to experience the peak and trough. The other issue that we run into, I think, is men need a lot of pellets. So like get 15 or 20 pellets thrown in your butt cheek every 3 or 4 months is like starts to be a little tedious and annoying.
Yeah. No, I think when I first started hormone replacement therapy, I tried pellets.
Yep.
And it didn't work for me because my metabolism,
Yep.
right? And I noticed I felt really great.
Yeah.
And then all of a sudden I was crashing and burning. And I'm like, I'm crashing and burning, people. And they're like, well, we don't know what to tell you.
Yeah.
Like, you have to wait your 3 months. I'm like, no, I'm telling you that I'm dying.
Yeah.
Like physically, like you feel like you're dying.
Yeah.
Like it's so hard. It's the crash. So I really love the injections. And it's funny because when I talk about this stuff on TikTok and things of that nature about hormone replacement therapy, people will always say, oh my God, you're on steroids. You're on steroids.
Yes.
It's like, huh? So can you just explain to the audience real quick, bioidentical hormones,
Yep.
okay, versus synthetic and steroids? Go ahead.
Yeah. So let's talk about the term steroid first. Our body makes all sorts of steroids, right? All steroid mean is it's a type of hormone. So you have peptide or protein-based hormones, right? And you have steroid hormones. Steroid hormones share the characteristics are they're made out of lipids, right? Cholesterol primarily. And their primary site of interaction is at the nucleus of the cell. That's all that steroid means, is it's a characteristic of a hormone, right? Now, anabolic steroids are steroid hormones that drive building processes in our body, okay? That's just a characteristic of what that steroid hormone does. Just like, corticosteroids, like prednisone, which is basically synthetic stress hormone. It's a catabolic steroid hormone. It breaks tissue down, right? So the term steroid gets used widely. Anabolic just means that it builds. So yes, testosterone is an anabolic steroid that our body already makes, right? People use the term steroid to reference synthetic derived compounds that people use in the sports performance world. That's where you're getting into like your androsterone like decadurabolin and masteron and primobolan and trenbolone and all these other. Those are synthetic derivatives of dihydrotestosterone, nandrolone, or testosterone that are manipulated to heighten certain impacts of how that drug works. They are not the same as something our body makes, right? Our body doesn't make masteron, right? It doesn't make primobolan. It doesn't make anavar. It doesn't make any of those things, right?
Right.
It does make testosterone, right?
Yes.
So bioidentical just means that the molecule of the hormone we're delivering is molecularly identical to a hormone your body already produces. So you're just replacing something that your body should be making adequately and is no longer making, right? So that's so hormone replacement therapy could be testosterone, but technically thyroid medication is hormone replacement, right? So it's it's just that the term, people hear the term steroid and it has such a negative connotation to it. It's dumb. It just references the structure and interaction of the hormone. And then anabolic just essentially speaks to the capacity of what that hormone does.
Right.
But yeah, bioidentical hormone replacement and buying anabolic steroids, anabolic androgenic steroids from like the fanny pack of the gym troll, like not the same.
Right. Definitely.
But I think it comes down to the ignorance, though. Like most people just don't know. So
Right. They don't.
when they don't know, they just want to say what they believe it is or think it is, which is the simplest way to go about it. So steroids, everybody kind of think they know what steroids is. So, oh, you're on hormone. Oh, you're taking. Oh, man, you're on steroids. Like,
Right.
Well, yes, technically based on the way Joe explained it, but based on what you think it is, no.
Yeah, it's different. Yeah. And okay, and also it's funny because when I talk to people, sometimes they don't know that women have testosterone.
Yes,
But then also sometimes they don't know that men have estrogen.
absolutely.
Okay, so let's talk about what does estrogen do for the body?
Yep.
And what happens with men using estrogen if it's too high, too low, all those things.
Yeah. So for men and women, estrogen and testosterone essentially do the same things for all of us. We just have different ratios. So estrogen, we know, is extremely endothelial protective. It's neural cell protective. So it's good for your blood vessels in your brain. It drives osteoblast activity. So you need it for bone formation. You need it for your connective tissue health. So it's an essential hormone for men too. With men, it's kind of the finite area of too much or too little. So too little estrogen, we're looking at cognitive decline. We're looking at reduced vascular function, erectile dysfunction. We can see compromised connective tissue health. Too much estrogen, men may start to notice like erectile dysfunction, bloating, water retention, gynecomastia, which is breast tissue development.
Yeah, I was going to say titties.
Yep, man titties. Yep. So it varies person to person, but I think really what matters with those values is the relative ratio that it maintains with testosterone. And then how much does it really change from baseline with therapy, I think matters too.
Okay. Very important then, right? Okay, let's talk about, I just want to say gonad, like gonad.
Yeah.
And so say the word for me.
Gonad?
No, it's
Gonadotrophic.
Gonadorelin.
yes.
Gonadorelin.
And every time I see the word, I just want to say gonads.
Yep.
I don't know why. I just do.
That's what it is. It's a gonad stimulant.
Yeah, I was talking about this podcast episode last night with Buzz, and I was telling him what we were going to speak of, and I just kept saying gonads, because I just want to say gonad. But okay,
we get a lot of interesting pronunciation of that in the clinic.
Yeah,
Gonad.
Never mind. I'm not even going to try.
Gonadorelin.
Anyways, it's
Okay.
fine. If you can't pronounce the word, it's fine. Say gonads. All right. So tell us what it is.
So gonadorelin was kind of the compounding answer to the FDA's regulation on HCG.
Okay.
So gonadorelin is an analog to a hormone that's called GnRH, which is gonadotropin releasing hormone.
Mm-hmm.
That is the hormone that your hypothalamus makes that tells your pituitary to make luteinizing and follicle stimulating hormone.
Mm-hmm.
Luteinizing hormone tells the Leydig cells to make testosterone. Follicle stimulated hormone tells them to make sperm. Right.
Okay.
So essentially, we use that when somebody is in using HRT as a maintenance agent for testicular function. It's a peptide, right?
Right.
When I say it's an analog to GnRH, it means it does the same thing that GnRH does, right?
Okay.
So we're using that kind of as a maintenance agent for the testicles. So we're still getting some level of pulsatile stimulus to the testicles to keep them active, even when you're taking testosterone.
Okay.
Other ones that kind of do the same thing, kisspeptin gets used sometimes.
Yep.
HCG was our go-to for a long time.
Mm-hmm.
HCG actually acts directly at the testicles. It was analogous to LH and FSH. So whereas gonadorelin's working higher up in the communication loop, HCG was stimulating the testes directly.
Okay.
Right. All of those agents, the goal is to preserve some baseline function of the testicles. Truth be told, I liked HCG better. It had a longer half-life than gonadorelin did. So I felt like efficacy was maybe a little bit better.
Right.
Gonadorelin just requires more frequent dosing. which is true of all peptides though, because of their relatively short half-life.
Right.
Yeah.
Right. Yeah. Yeah. I mean, because we work a lot with peptides, right?
Yep.
And then, we are obviously doing different things. You can inject peptides, put some of them on a iontophoresis patch. And a lot of people will ask me, why can't you put a GLP-1 on the iontophoresis patch? Why can't you put testosterone on an iontophoresis patch?
Yep.
And I think like what you said, some of the half-lives are longer.
Yep.
And then for testosterone, it just doesn't make sense to me personally.
Yeah.
Right.
And I know with the ionto patch, it's not like broadly applicable to all molecules either,
Right.
because the size of the molecule makes a big difference as well.
Right.
Ideally, you want, 500 Daltons or less. So different drugs have different sizes too. So
And was there anything else that you want to talk about? I know that also you guys are using AI, right?
yeah,
Not AI is what you think.
yeah, not exclusively and not with every patient. So
Okay.
like aromatase inhibitors, I don't like to say that they're always inherently good or always inherently bad. I would say it's like any other tool whose hands you put it in.
Okay.
Right. So aromatase inhibitors, essentially what they do is they occupy the aromatase enzyme so that testosterone can't bind to it with such a high affinity. And what that does, or high frequency, what that does is it controls the rate of testosterone to estrogen. Now,
Okay.
you definitely do not want to go full nuclear option on estrogen, right? We don't want to ever shut anybody's estrogen down for all the reasons we just talked about,
Right.
the consequences of low estrogen. But for some patients who are, I'll be honest with you, it's normally patients that are quite a bit heavier set or have a little bit higher body fat. They tend to aromatize and store estrogen a little bit more aggressively. So if we increases somebody's testosterone 300%, we don't necessarily want to increase their estrogen 300% either. So if absolutely necessary, you can use very small doses of those to control the aromatization profile. It's not something we do with everyone. In fact, we've got a fair number of patients that don't require it at all.
Okay.
And generally as patients, therein lies the argument for microdosing as well.
Yep.
Smaller, more frequent dosing generally helps naturally control that profile also.
Okay.
But yeah, we do occasionally use them situationally as needed, although it's not something we necessarily always wanted to defer to, like right out of the gates.
Yeah.
Yeah.
Okay. And so now let's talk about when a patient comes in and they want to start hormone replacement therapy and you pull the blood work.
Yep.
And I want to mention this because a lot of people, we are so programmed. If we have a problem, if we have a symptom, we're getting a pill and it's gonna, like, we're taking a pill, we're doing this, like it's gonna help immediately.
Yep.
So tell us, like, what can people expect, especially men? Like, how long does it take to get their levels where they need to be? And how long are you assessing them? Like, how often are we doing blood work?
So, I mean, most patients will notice some subjective improvement pretty quickly in the first couple weeks. Part of that's probably placebo because they're aware that they're taking it. It may take 6 or 8 weeks for us to see blood levels stabilize. So I always tell patients with testosterone replacement therapy, and this is true for women on HRT as well, I always tell them to envision your progress like you're walking up a flight of stairs, right? Most patients notice incremental improvement kind of week by week, where the first 2 to 4 weeks, they may say, maybe I kind of noticed something. I don't want to take a nap, or, I'm waking up with an erection every day and I haven't done that since high school and things like that. But when we look at like the downstream metabolic changes that testosterone may influence, and with that comes the whole subjective profile and the things they experience, I tell patients changes in 2 to 4 weeks, you may start to see things, but we really need to give it 8 to 12 to get a full response to know exactly how you're going to feel. And within there, we want to recheck blood levels as well to make sure that we have you on the right dose. So we generally reassess 6 to 8 weeks after we start care. And with that, we'll do a subjective follow-up as well as far as what's changed, what hasn't, and then adjust thereafter. And once somebody's stable, every 6 months or so for blood work, as long as they're feeling good and their levels have been stable for a while.
And sometimes when I talk about hormone replacement therapy to, we talk to a lot of providers and they'll tell us, I feel like trash, this, whatever. And I'll start talking to them about hormone replacement therapy. They'll say, I don't want to do that because I have to be on it forever.
Yep. So the concern with that is long-term suppression of the HPG axis, which is hypothalamus pituitary gonadal axis. So if you just start taking testosterone by itself, right, you will shut off the hypothalamus and pituitary. Communication to the testicles will stop. And I say, like, the testicles are just doers. They just make stuff, right? But they're not self-regulatory. They're not self-governing, right?
Mm-hmm.
How much or how often they produce is still dictated by the hypothalamus and pituitary. So if you take exogenous test and you push your level therapeutic, the brain and pituitary respectively are going to be like, hey, we're good. We got enough testosterone. We no longer need to output or drive output from the testicles.
Mm-hmm.
Well, the testicles are like any other tissue. I say this is like an oversimplified example, but it'd be like if you tied a hand behind your back for 5 years, at the end of 5 years, expected that arm to be able to do all the same shit.
Right.
You'd have atrophy, you'd have tissue loss and things like that. The testicles are the same way. When they go metabolically dormant, they're going to atrophy, they're going to become less metabolically functional. Some of the cells are going to die.
Yeah.
The longer they're dormant, the less likely they are to return to pre-existing baseline function.
Mm-hmm.
So that's why we use those other ancillary agents like the GnRH or the HCG or kisspeptin to maintain some baseline level of function so that if somebody does come off after a few years, we haven't just, gone full nuclear option on their endocrine system and left them in a completely depleted state and trying to kick back on testes that have been dormant for years, right?
Yep.
I say, like, if your baseline level is 300 relative to total, let's say we treat to 900.
Yep.
The goal would be if you come back off, you're going to float somewhere back around 300 or 400, right? The likelihood that you don't start TRT, start at 300, go to 900, come off, and magically you stay at 800 or 900. Doesn't work that way.
Right.
Our goal is to maintain that pre-existing baseline, because what we don't want to have happen is you start at 300 or 400, you treat, you're at 900, you come off, and now your new baseline's 100 for the next 2 years, right? Because of damage to the endocrine system.
Yeah. And so I guess also, so the audience that is listening, who is a good candidate for HRT? And I know that we hit on some things earlier, but it's like, if you're really feeling like these symptoms, that's what I want.
Gosh, anybody that symptoms warrant and lab support that is in fact the problem, right? So HRT isn't like blindly for everyone. For example, if somebody comes in and they say I have low T symptoms and and they do not have low testosterone, well, then low testosterone is not the creator of your symptom. It's something else, and we need to look elsewhere. Maybe it's the adrenals, maybe it's the thyroid, maybe it's your diet, maybe it's the gut microbiome, maybe there's an abnormality in like a metabolomics, and that's why we have all those other tools.
Right.
But what matters, I think, is that, there's actual room for improvement. Like the intervention is going to be meaningful, and there's enough room for us to move that it will actually stimulate a significant change. 2, that there's no, obviously contraindications. And then 3, that you're fully educated in the subject matter and you feel that you're, as a patient, informed to make the choice that's right for you.
Right. Okay. And so what's the biggest takeaway men should basically leave with this episode?
TRT is safe and effective when managed by an appropriate managing physician that knows what they're doing.
100% agree, because we hear, I get all the time, hey, listen, can I come to your husband's clinic and can I just get X? Can I do this, this, and that? And then I'll be like, where are you even going?
Mm-hmm.
And then they'll just say, I'm going here and this is what they give me, blah, blah, blah. And more is not always better, people. Like, more is not always better, right? So
quite the opposite tends to be true with time.
Yeah.
So I'd say, I can't remember what question you asked me originally.
What's the biggest takeaway for men?
Biggest takeaway of that is that if you're managed by an appropriate physician that knows what they're doing, like, you're in the right place. So you got to be confident in your care provider.
There's a lot of these like pop-ups coming up everywhere, right?
Mm-hmm.
To treat hormones. And it's very concerning, because I feel like you definitely have to go somewhere. And I always tell people, like, do you have like an anti-aging or a regen clinic in your space? Like, where are you going? And when people say, and I'm not saying this, modern medicine, they're not in the wrong. They just don't know in depth about the blood work, or they're not asking the right questions maybe, but they're really not checking the full blood work like we would, right?
Well, and they're not delving into what else could be the problem, because testosterone only fixes one thing.
Right.
Low testosterone. Doesn't fix anything else. So you also got to have realistic outcome predictions for your patient, right?
Yeah.
Where it's like, okay, testosterone fixed your low testosterone, but the HPA axis is a mess. Vitamin D is deficient. You've got fatty liver. You've got all these other things. You got a really advanced metabolic disease profile. Like, if we fix one thing, then we fixed one thing. All of these issues are not going to go away.
Yeah.
Testosterone may acutely mitigate some of those symptoms because it's strong enough to help kind of blunt the effects, but all those other things matter.
They do.
So we're big proponents of TRT and hormone replacement therapy in general for men and women, but we also never claim that it's a fix-all.
Yeah.
Right. So you really
It's
want to
just one little tool in the toolbox, right?
right. You
That's
want
what
to
it
be with
is.
a provider that is willing and capable to pull in the whole profile
Yeah.
and expand on the other things you may actually need if you want to get the outcomes you want.
Yeah, it's very important. I highly agree. Would you like to add anything else? No?
Well, I will say this: Joe Matovich is one of the best at what he do. So come down to Buckeye Physical Medicine and Rehab, and you're gonna be treated by the best.
Yeah, I agree. I'd agree. So if you're listening to this episode on Stop Feeling Like Shit, and you could be a wife, a female, you could have a son, a husband, a boyfriend, an uncle, whoever, it doesn't matter. And if you're like, you know what? Wow, that sounds like them. Like they feel like shit. They have low energy. Maybe they have low libido, all these different things. You can message us, hit us up if you're local. Definitely come into the clinic and talk to Joe because truly, I mean, I was going through it and he fixed me. So that counts for something, right?
Yep.
Yeah. All right. So stick around. We have another episode coming, and this one is going to be one of my favorites. Thank you guys so much.
Well,
And stop feeling like shit. We'll talk soon.